The information in the following video series includes professional suggestions that should be implemented by a licensed PT. Hi, I'm David Lawrence, founder and CEO of the Mission Gait Foundation. This is the second video in our series on the neuromuscular rehabilitation of the foot and ankle complex. In the first video, I introduced core principles and biomechanical considerations that are important to keep in mind before you engage with the patient. So, with that information in mind, in this video I want to focus on the progressive treatment of the patient. I'm not going to provide a full foot and ankle evaluation, though this would be good material to review. However, I will stress that you need to couple macro gait assessment, if initially possible with weight-bearing status of the patient or the limitations thereof, with microstructural evaluation of the foot and ankle. This information sets the tone for your manual care interactions and your hands-on exercise instruction to create a progressive and adaptable treatment plan. Rarely does a treatment course go exactly as planned. Every session must include an assessment of the patient's response to your treatment and your treatment plan, and to the progression of their weight-bearing status. Now, it's important to note that therapists need around 50 to 60 minutes to provide true quality hands-on care to every patient. You will see in this video why this is so important. All right, let's get started. So, first thing we're going to be doing is looking at reestablishing soft tissue extensibility, segmental joint mobility, and comfort, working all the way up through the spine as needed. Remember, sometimes we focus only on the ankle joint, but someone may have been walking in a boot or cast or something for a long time period, have issues that go all the way up through the lower quarter to the spine. So we want to address all of those issues. First, though, what I want to talk about is soft tissue mobilization. And really that breaks down to me to be three things. One is incision line healing. Two is movement of fluid or swelling out of the area. And number three is contractures, tightness, stiffness in the muscles themselves. So number one of the things we forget about many times is that if you have someone that is coming out of surgery, now not every one of your patients is this way. You might be seeing someone with plantar fasciitis or posterior tib tendonitis. But if you're coming out of, say, a trimalleolar fracture, you're coming out of a displaced compression fracture or a displaced fracture of some sort, an open fracture, all those types of things with ORIF or hardware inside really take a lot of attention to the healing of the skin as well. Remember, that skin, largest organ in the body, must be free from everything below it. But the way the body's healing is putting a lot of collagen into that area and then identifying that collagen once it's there. So it's really easy for adhesions to occur between unlike tissues. Subcutaneous tissue to the scar, to the skin, I should say, also down to the bone structures, and to even like the head of a screw that is in holding hardware in place. So right off the bat, what you want to look at is common places that you'll see an incision line. One is right on the bottom of the foot, and this tends to be a very painful area and very uncomfortable for patients in general. You want to start working on this really right out of the gate. And what do I mean by that? If you think about normal tissue healing, there's time frames that are important. First 5 to 7 days is the inflammatory phase. You kind of want to just leave it alone. Between 7 days, 5 to 7 days, all the way up to 21 days is the fibroblastic phase. There you can be involved with that incision line. And then once you get to 21 days, you actually want to be putting some stress and cross friction on that incision line, slowly at first and then developing. This is something you want to do as a therapist and then teach your patients to do to themselves. But if you think about this and we look at an incision like we have here, hold that foot back just a little bit for me. There you go, perfect. We're going to come to this guy and you see it. What you want to do early on is put your fingers on both sides of that and approximate it, hold it together, and then just move it together as a unit. You're not stressing or straining it. You're just moving it together as a unit, both fingers doing the same thing, so that basically you get movement of the skin over the underlying tissue so it doesn't heal or adhere to it, but at the same time you're basically not putting stress to open or strain that wound. Now in the same process you would do that from the side. So if we're looking over here, which you'll commonly find those incision lines coming down the side and on the outside of the foot. And I will say one thing real quickly. This is a Sharpie. Normally, in most of our videos, we like to have actual patient models, and if at all possible, we do that. In this particular case, it just wasn't possible at this time. So Hunter has been kind enough to sit in for us, or lie in for us as to be our model. But basically we look at that same tissue. When you come here to that incision line, I want to get a hold of it, hold it together, and then just move it around gently. That's what I'm going to be doing between that first week and that third week. Once I get to that third week, I'm going to come to one side of it, and you'll see I'm more deflecting that in that line. It's moving a little bit from side to side with a little bit of tensile force, but really not hard. And then eventually, a little bit farther down the road, 4 weeks out or so, I'm going to get my finger right on that incision line and work it. Most of the time, you're going to have steri strips in place. The doc will say, don't peel those off, and I agree with that, don't peel them off. But at the same point, you want to be massaging right over those steri strips so that gently the edges of the steri strips, in particular, more proximal at first, here will start to fall off first. But you come right through that and just work that incision line all the way down, creating mobility. That decreases sensitivity and also decreases those adhesions that form underneath. Remember, a lot of times patients go to move later on, they're trying to move, and part of that is the skin is adhered to their underlying tissue. Their limitation isn't the joints underneath, it's actually the skin and how you've healed. So very important to deal with. The second thing we talked about is moving soft tissue, and that's fluid. So if you got any one of your patients, I guarantee you they're going to have a lot of swelling. If they're up and moving at all, that swelling is going to tend to be draining down to the foot. So whenever possible, higher than the heart if possible, but in therapy I'm always going to do a little bit of work, really working that tissue, soft tissue, back towards the heart. I'm going to come up through and just pushing everything right up to around the knee level. I'll just spend a couple of minutes doing this with the patient. Now, a couple of things that happen with this is, one, I'm spending a lot of times hands-on with the patient, which is helping them feel a little more connected and a little more aware of what's happening. One of the biggest complaints we get a lot of patients that come from other places that have not done well, and one of the first things we always hear is, no one put their hands on me. They didn't really hardly touch me. Or the therapist is there for 5 minutes and then turned me over to an unlicensed person, that younger person had me go through exercises with no one supervising. So you'll find very clearly we spend the time with the patient to not only work on that tissue, but while I'm working, I'm also talking to the patient. Hey, here's what's happening. Here's what's going on. Because I get, again, another comment from patients a lot is, I learned more in this first session than in the last 2 months I had physical therapy, because no one really told me anything. And I really want patients to understand, here's what's happening. Because you know it is, if there's a lack of information somewhere, your mind will fill the void. And it's going to probably fill the void with worst case scenario. This is terrible. Oh my gosh, that pain's a horrible thing. You may be saying, no, this pain's a good thing. This means you're healing. That means, you know, the nerves are coming back. That fluid, oh, I have all this terrible fluid. Of course you do. Your body is generating a lot of fluid to try to help you heal. We just need to move that fluid back towards your heart. And the other issue then becomes soft tissue, is getting into, especially in the Achilles and the calf, where a patient's going to have a lot of tightness. And if I can work on that and just help them loosen that up, really get a little bit more motion there, a little bit more, and again, will be tender? Sure. That calf's going to be pretty tender. So you look for those tender areas, and you're trying to convince that patient also get involved. If this is going pretty well, you can do the same thing, right? Your spouse can do it, or you can do it. Move that fluid up. You can get into the calf and massage it and work it at the same time. All the way through that process, whenever possible, you want to get that patient involved. Because the more involved they are, the less fearful they are of the situation, the more they get engaged with the therapy versus being apprehensive to the therapy. So a lot of hands-on time, a lot of work on soft tissue to get things moving, and this is going to progress. Every session with the patient, am I getting more mobility? Is the incision line moving well? Is it less sensitive to the patient? All those things are positive, as well as the fluid coming down. Now again, as a progression with the patient, one of the things I can do is utilize something like a foam roller. And a foam roller is something you just put right in behind the patient, in between their, behind their leg, and I just have you kind of bend this knee a little bit. I just want you to kind of slide yourself, roll yourself back and forth over that guy. So if you're just rolling back towards your backside, there you go, and then roll out towards me, you're not going very far. Just roll that guy. He can roll it to the outside, and just say, oh yeah, it's really tender. Right down you don't have to do anything right down on the incision line, down to it. He can roll it to the medial gastroc and really get a lot of motion all the way down, all the way up, working that guy. At the same point, remember, everything's going to be tight. So the same process, you can take that same foam roller, put it here behind the knee, and just roll down towards me. So you come right onto that hamstring and right off. Same thing, medial, lateral, looking for tight spots. You can roll that right up into the backside, work on his glutes. You can also use a larger foam roller and work on rolling his back. All the process here. Again, here's his non-weight bearing foot. Still, the leg is getting a lot of therapy and a lot of interaction without the foot having to take a lot of load. So easy process for him to continue to work on. Good, perfect. I'm going to set this guy out of the way. So the next thing we're going to be talking about is joint mobilization. Because not only, obviously, do we have that skin mobile, those internal joints. You remember, when you take the hands and the feet together, you got more bones there than the rest of the body combined. All the bones in the body combined. So what we're talking about here is a lot of different individual joints inside that foot that have to be mobile. Maybe not just the ones that were fused in place or have hardware attached to them, but everybody else also is going to be very stiff in the foot. So I'm going to come down to that foot and really look at the motion of the foot itself from top to bottom. So many times with a patient, instead of starting right where it's uncomfortable, I'll kind of start where it's not as uncomfortable. So I'll come up here, maybe even start with the toes, a little bit of digital traction, distraction. A lot of times you'll get a toe to pop and the heels will say, oh, that felt good. Just kind of freeze that tension up. Well, right there. All right, and I'll come here and then I'll come right into the metatarsals and do a good metatarsal glide between each metatarsal. Just saying to that foot, okay, you've been a club for a while, kind of jammed up into that boot or in that cast and not moving very much, or because of pain, you've been holding the foot stiff. Most of our patients really, right, when they're in pain, they're going to walk really inverted and on the outside of that foot, a lot of tension in the foot. So I'm coming right through that. Then I'm going to come all the way up to those mid-tarsal joints, basically where the metatarsal is attached to the tarsal joints, and work and just see what kind of glide we have between each of those joints. And then eventually here we get right up to the talocrural joint. And remember, that's a dome, the talus, moving in the mortise, which is basically a concave structure. So with that guy, we're going to roll over here and look at what happens. Many times when I go to articular stretch somebody into dorsiflexion, they're going to say, well, it's not just tight here, it kind of hurts across the front of my ankle. And a lot of that is because you're getting impingement of that talar dome. So with a patient, very clearly what you want to do is get a hold of that guy, get a little bit of distraction, and then just do a drawer test. Basically what you're looking like an anterior talofibular ligament tear test. You're just gliding that foot forward and back. Now, most important glide is actually posterior. That posterior glide is going to help clear that talar dome. So basically I'm doing this mobilization right here. And just up and down, and at first with the patient, remember, always give them a little bit of distraction, take some tension off the joint, a little pressure off it, and don't start with a big heavy motion. Start with a very slow glide. Talk to them the whole time, distract them, get them thinking about something else. Tell me about your grandkids, whatever it happens to be. Get them thinking and then think, okay, now I'm going to go a little bit bigger glide, and then you can see their face kind of make a little bit of a grimace. You're going, okay, I'm getting tight. I just want to work that joint the best I can. Now I want to get that posterior glide though. So from there, I'm also going to come in here and grab that foot and create a downward pressure. So I'm here and getting that really good posterior glide. That posterior glide is going to give me the motion I need to allow improvement in dorsiflexion or motion coming forward. Now, next thing, this is not where you stop your mobilization. Most of these patients, especially if they have any hardware, also have a fibular head issue. Things are going to be very tight. So you want to come all the way up through this guy and get to that fibular head and basically work on those glides. There you go, that anterior posterior glides of the fibular head. And you can do that at various angles of motion, but just making sure that that fibula, because remember that perineal nerve wraps around there, and if it's not moving well, you can get some compression of that perineal nerve. So moving that perineal nerve. At the same time, assessment-wise, I'm going to come all the way up through, and I'm going to check the knee, I'm going to check the glide here. IT band's going to be tight, guaranteed. I'll check the hip. Why? Because sometimes in the last patient I had who had a fall, she had fractured her, it was a open fracture of her ankle, tib-fib displaced fracture. That was so bad, that's all they focused on. Didn't realize at the same time she tore her ACL. No one ever even looked at it because it really wasn't, this is like dramatically her foot's out of position. So once we came up here and realized, oh my gosh, she's got an ACL issue, she had to rehab from here, but then she realized, okay, I've also got an issue here I have to deal with. So those things can happen. You want to make sure that just the most obvious thing isn't capturing so much attention, you don't look at other issues that in the area that could also be a problem. So joint mobilization wise, really important each session to assess how much mobility do I have, how comfortable is it, how much movement can I get from there. So next issue from there, we start looking at the idea of using modalities. Now over here we have an ultrasound e-stim machine. I'm not anti or pro modality. Modalities for me are really good for the idea of creating a more optimal environment internally for healing to occur, or to make the person more comfortable. Because remember, a lot of this issue is going to be painful. So if you aren't convincing that patient that, okay, some of this pain's kind of normal and it's okay, but also I want to limit that pain and it's more comfortable each day, they're going to feel more comfortable with their ankle. So modalities can be useful, ultrasound can be useful, e-stim can be useful, and definitely we use some based on the patient and what we think the needs are. So again, not saying it's good or bad, it's a tool that you can utilize. Now, we talked a little bit about rolling and rolling that foot, or rolling the back of the leg. The other thing you can have that patient do is roll the foot itself. So I like to use a Coke bottle. Just take a Coke bottle, dump the Coke out. I keep one for myself for my own plantar fasciitis in my freezer. Pull that empty Coke bottle out and I roll the bottom of my foot. Again, something can be sitting down, obviously not standing, and just rolling that foot. Anything you can have the patient doing for themselves at home that's going to create some comfort and some movement and more mobility within the foot is the key. Biggest mistake early on is people make is two things. One, undertreat it, don't do much with it. Or number two, try to really work hard on getting power back. This is not the time to get power back. This is really the time where you want to focus on getting mobility back. And that leads us into the idea of stretching. Now, we always want to work on stretching and mobility, but you're going to work on starting with that calf gastrosoleus complex. One of the ways to stretch that is to start with a little bit of the soleus contact. We're going to use our same foam roller in here. We're going to use, and you can use a stretch strap, whatever you want. You can use a belt, you can use a towel. You cannot use a TheraBand. I have patients all the time say, I got my TheraBand at home doing my stretches. Well, TheraBand's stretchy, so that doesn't help you. TheraBand can be a good exercise tool, so pull back and then work into the TheraBand to get some strength back. We'll talk about that briefly. But really, if we're working on flexibility and mobility, you need something that's non-elastic. So if we take a stretch strap like this, and put it around, bring it to that patient, good. Now all I want him to do to start with here, sit up a little bit for me if you don't mind. Perfect, and keep that ankle, there you go, that knee bent a little bit. So as you pull back on this guy and get a little stretch, you're gonna get more soleus. Now with that knee bent, what are you going to get? Soleus, but you're also going to get ankle impingement. So when that glide, you want to make sure we've done the glides, and sometimes you can do that and then don't do the glides, have them feel that impingement, glides, and say, oh, that feels a lot better. Great, now you know that's an issue that we can utilize to help you. But at the same time, what I want from him is not just stretching. So at this point, I want oscillation. So if he comes out and says that he feels some impingement, I want him just to oscillate that impingement a little bit. Don't just yank on it and hold it, right? Just gently oscillate that guy to feel that impingement reduce as the joints start to articulate better. So don't be afraid. I was always taught when I was young, never bounce when you're stretching. The reality is I think some gentle bounce, especially when you're dealing with more joint impingement, is actually helpful as the body relaxes more with oscillation versus just constant tension and pressure. Now we take the foam roller away, and he simply just comes down into a calf stretch. He says, okay, yeah, I feel that higher, I feel a good calf stretch, no problem. Here's a basic rule about stretching. One of the things I see done wrong most of the time is stretching is going to be taking that muscle and elongating it. But remember, that muscle has in it protection mechanisms or self-defense mechanisms in the muscle tendon junctions that tell you if you're pulling too hard. So and I see people in the gym all the time, yanking back, you see grimace on their face, or yanking hard, you're going nowhere with that, right? Because those defense mechanisms have kicked in, that muscle's not going to allow you to stretch it. So basic 10-10 rule that I came up with years ago really works well for me. I have a patient come on, put a little tension on that thing until they say, okay, it feels stretched, but not pain at all. Just a slight little bit of stretch. Don't pull any harder. Give it a few seconds, 5 to 10 seconds. Take a deep breath, exhale, let the body just totally relax. And then pull back for the second 10 seconds into a really good stretch. At that point, you've kind of turned off those defense mechanisms, allowed things to relax a little bit, and really created a very good stretch. And you repeat that each time. Gentle stretch, hold for a little bit, release, take a deep breath, a little bit of release, feel everything relaxing your leg a little bit, and then pull in. That way the defense mechanisms aren't fighting you the whole time. You can also use some PNF techniques, are wonderful, there's lots of different things, but just sitting there yanking on your leg, never a good idea. All right, and you do that same principle all the way up. You're going to do your hamstring stretching, your calf or your quad stretching. piriformis, IT band, every one of those things you teach that person to stretch. And this can all be done pretty well as non-weight bearing. Even here, I tell them don't yank on it hard, but even though you're non-weight bearing, we can still do some gentle calf stretching. We just don't put too much pressure on it. That's just going through that motion to get the mobility that you're looking for. All right, you'll see we spend a lot of time on soft tissue mobilization and joint mobilization. That's exactly right. We spend a lot of time on the patient with that, especially early on in the process. Over time, you don't have to do as much. But we also want to introduce basic ideas of non-weight bearing, if that's what they are at this point in time, motor activation into initial motor control, and comfort. In other words, exercises should actually improve comfort because you're not trying to work hard at this point in time. So really important with the patient is get them to understand I need movement, but you're not trying to cause pain. And a couple of basic exercises are ankle pumps, right? Where you come in, put something behind that ankle just to clear the heel, and just have that patient pointing as low down to ballet dancer as high as they can. Say, well, it hurts bad when I pull back that hard. Then don't pull back that hard. Go close to that, but don't force your way all the way into motion. Just come to it. I like to use what I kind of call the door theory at this point. When you're thinking about pain or restriction in motion, if you come up to a heavy doorway and you just stand next to it, nothing's going to happen. The door's not going to move at all. But if you take that same door and jam on it really hard, it's likely to slam back in your face. But if you come back to that door and just come up to it and just gently work it and let it go, don't force it, and just each time gently work that foot, that door, it's going to start to move. And that's really what we want to do. We're in this process now, not trying to conquer the world, but also not sitting there doing nothing. We must find that in between. So, and the other thing you'll find is I got my hands on the patient. A lot of times I'm going to help them through that motion. Easy for Hunter, but to a patient who's just come off of surgery, their foot feels very clumsy. So they don't even really, basic pumps are hard for them to understand or to even feel. And then a progression from that is the idea of imagining that you had a pencil between your the middle and second, or first and second toe, I should say. And you're going to write the alphabet in really big letters. So you're going through those lettered motions. Great thing to do, just a simple, getting as much motion and movement as you can. The next one on that is toe flexion and extension. Having the patient just scrunch down like you're trying to grab onto something with my foot, and then extend and splay those toes out as wide as I can get them, and then come right back down into scrunching. Again, not painful, and if you can do this with your ankle higher than your heart, you get some good movement of fluid out at the same time that you're getting decent motion. And then when the patient comes from here, you can have them sit up and do scrunchers. So they're sitting with their feet on the floor and either doing marble pickup. That's where you pick up a marble and moving it, just working on control. Seems so simple, but patient coming out will feel very hard to have any dexterity in their foot. And then the towel scrunchers, where you're scrunching that towel in. Remember, that towel needs to be on a smooth surface, or at the home, could be on a towel or on an linoleum floor, and just sliding that towel in, working those intrinsic muscles of the foot. All right, you can also do from there things like a seated BAPS board, moving in different directions, trying to get movement without pain as much as you can. Toe yoga. The tennis ball lift, that's kind of really for posterior tibial tendonitis, but it's also just a good motor control exercise for the foot and ankle in general. And toe yoga is moving this, separating that big toe from the other toes, and that motion of being able to go back and forth. Again, seems so simple when you see it on the video, but trust me, when you first try and do this, it's difficult, and it'll be very difficult for patients to do as well. Okay, now we're going to start talking about weight-bearing exercises. Assume your patient has now gone to weight-bearing as tolerated or full weight-bearing, and we're going to look at our motor control under load, progressing to power. Now remember, with this, we're going to have a number of different things you're going to see that we're going to do, and there's always a progression, and how you can progress it is, in my mind, not speed at the beginning. We're never trying to go for speed. We're going for everything under control, very intentional, very aware, very thinking about what's happening. A lot of these things, the patient has never really thought about how my ankle works. They've taken it for granted for whole life. And now they got to really start thinking about something I've never really had to put any time into, and it's a dysfunctional ankle. So we need them to really pay attention and slow down. So I don't want to change the speed. What I want to change is things like the surface. Make it a harder surface, a softer surface, a more pliable surface, more of a stretch position, visual feedback. That's why we love the mirrors. So the patient can look at themselves and say, what I think I'm doing and what I'm actually doing are the same thing. Great, or take the mirrors away, or take the eyes away, so you go with eyes closed. All those factors change that feedback. The other is multitasking. I can have someone doing a drill and then focus on that while they're bouncing a tennis ball against the wall. So they're focused on dual tasking that process. And then ultimately what we call impulse or agility, adding some slight amount of impact as I'm going to slowly increase that impact. In our third video, or last video, we will focus a lot more of high intensity activities as we get someone back up to that level. So all the exercises start slow, they start focused, they start intentional, and they progress with amplitude and then eventually with speed. So if we look at the exercise Hunter was doing earlier, seated position. Now if he does this standing, same thing, gripping that tennis ball and just doing that lift. Really good exercise for the posterior tib, but in general, just a good strength, control, and awareness exercise. Make this a little bit harder than just standing. Hunter can have you step forward. I'll move the ball for you. And just put yourself on a surface. There you go. Grab that. So now he's starting in a little bit of dorsiflexion and working through a larger range. Great exercise, simple adjustment, but just makes a little bit more work for him going through that process as he's holding that tennis ball, lifting up and coming down. Perfect. All right, so when an AirX mat works really well is just the idea of getting a sense of a softer surface, patients kind of newly weight bearing, and just get a sense of what do my feet feel like on the ground. You want to look in that mirror, look down at your feet, and look to see, keep kind of an equal dent in the mat. Many times when people get up, they'll see a real heavy dent on the sound side, and the other side's not even putting a dent in the mat. So you might want to look down and just say, okay, make sure that dent on the mat looks about the same depth, and they'll go, gosh, it feels like I have way more weight on my involved side than my other side. Well, you don't, but that's what it feels like, and that's what we have to retrain the brain, that what you've done for months in healing and protecting, now you have to flip the script on that and get your weight back on it. So the one way to do that is then weight shift. If he weight shifts into that involved side, he might want to use his hands for support to start with, and then shift away from it, but he's just moving that weight shift control on a softer surface. He can do that same weight shift control front to back. He can do that same weight shift control in circles in different directions. And then ultimately we progress into single limb support. So if he's standing with the one foot in the middle of the mat and lifting the other foot up and just working, can I begin to get some control from that position? I can progress that also into heel lifts, bilateral or single limb. I can also progress that into eyes open or eyes closed, but keeping your hands up for balance control as you're getting a sense of awareness of position in space. Again, with a rocker board, what I want to do is change the surface, make it more unstable. So all I want you to do is once you go forward and back, touch in the back, feel the control, feel a little stretch in your calf, that's okay. And then come all the way forward and touch the front. Feel your knees a little bit bent, a little bit more weight in your quads. Feel that work to the front. And just return back and forth, going from that stretch position into that control position. Good. From there, he can come to the center and hold and try and find his balance there. And remember, if his feet are moving, the board's a little bit active, that's good. I always talk about the guy on the surfboard. He's not standing there like a statue, he's working the board. You want a patient to be working the board. And the most complicated or the most advanced is have him do a quarter squat. So he's going to squat forward. Always got to tell him, remind him to keep a lot more weight on the first med head, keep that weight a little bit more forward in the foot as you go down and you come up. But control that board position while I'm taking that ankle through a lot more motion than it's used to. Perfect. Now we changed the rocker board to side, and I still want Hunter just to work on light touch from one leg to the other. One thing that's really important about this, and I always start with front to back first, is front to back, the two legs are helping each other. They're working as a team. Here the two legs are contrasting each other. Whatever one is doing, the other one is doing the opposite. So it makes it much harder for that weaker leg to keep up, to be an opposing component to the sound leg. So, but back and forth, just working on that sense of control without slamming down on one side or the other, light touch to light touch. And then come back to center, find center. And again, with hands off, you'll find with the knees a little bit soft, the board's going to be moving a little bit. Again, patients have this mistake of thinking of balance as a statue, a stiffness. It's not. Balance is movement, constant movement. It's just micro movement. The better balance you are, the less movement you're going to have. So what you need is to see that board moving, but mainly right at the ankles, and the ankles become less motion as they get more control. Now, the last one is the squats. So he's going to do squats, and many times when you come to squats, you'll see the legs start to quiver a little bit. Because again, they're trying to figure out how do we work together as a team. And a new patient, I always usually have them put their hands on because they're going to get really quivery, and that kind of scares them. So at the beginning, no problem. Put your hands on until you kind of get control, and then over time, you realize that quiveriness is just your brain working out that control issue. Next is starting to get some great little exercise using the TheraBand. And you can do this at home, just putting the TheraBand around a kitchen table or something fixed at home. I carry this with me whenever I travel, so it's in my suitcase. I'm in a hotel room, I can do a bit of a workout. But what this really does is a nice job of working dynamic work on this particular case with the left leg and static control work with the right leg. Most people think, well, the band's on the left side, that's where I'm gonna feel it. No, you're not. You're gonna feel it on the stance leg on the other side doing all the work. But I'll have them go ahead and just do an extension back, nice and slow, as far as you can. Hands on to start with for control. Takes the hands off because it also becomes a balance tool once you have better balance control. So he's working on coming all the way forward and then all the way back. So through a nice full range of motion, all the way forward and back. And he can go through that progression in all 4 planes of motion. Backwards, side, inward, and then pushing to the front. So all 4 planes of motion he can go through. He can do it with hands on for support. He can progress that to taking hands off and getting more and more control. Once he does a set, I like to do a set of 20, slow and controlled in each position. That's 80 repetitions. Then switch the band to the other foot. So if he just basically, the easiest way, exactly, step in, step your other foot out, and repeat that process. Mini tramp is a great little tool to get people to get a little bit of weight on that leg without taking so much impact force. Remember, impact is going to be very uncomfortable. So getting on a little mini tramp gives him a little bit of give. So he can just do little squats, put a little bit of ankle pressure in, a little bit of upright, and just say, how does that feel? Put a little more pressure on it. So one of the things we want to do with a mini tramp then is begin a little impact. So I just want you to do a little hop up in the air and then land with really soft knees. There you go. He starts with that. He's barely putting it on, but just beginning to take a little bit more impact. As he feels better, he can get a little bit of air, but he's not meant to get a lot. He's just not so deep, just gentle, easy motion up and down. And he can progress that to one leg, which is 1 foot on the ground, and just that involved side taking some load. Bosu is another great tool, and I love to do what I call lunge step-ons with the Bosu. In a stable position, you can get some sort of step, whatever you need to be about the same height as the Bosu. All I want Hunter to do is a step to the middle of the Bosu, a little bit past central with his involved leg. There you go. Bend that knee and do a lunge. Use this hand for support. Bring the other foot off. And just get himself leaning right into it, pushing that Bosu down to the front. He'll feel his quad really engaging, getting a little bit more foot load as that Bosu gets a little wobbly. And then he pushes off and steps right back out of it. If he gets in any trouble, I always tell patients, you can just step right off of it. You don't have to try to catch yourself to step off. As your progression gets better, you take the hand away and see if you can do a step and come forward and hold that stability with the other foot coming off, and really keep that stability. You can tell he's working hard, but again, not putting too much pressure on the ankle at this point in time because it's coming the pressure on and off slowly. I also really like using Dynadisc in lots of different ways, but one of the ways fairly simple is to say put the sound foot on the Dynadisc, so more work has to be done on the left side, and then just have doing like tennis ball pickups. So we just lean it in, and get that patient to bend that knee a little bit more. There you go. Bend that involved knee into it and out and back down. Now, as he progresses, then he can step to putting that left foot on the Dynadisc. And this, if he can do it, lift the other foot in the air and hold his balance and come down and try and lift that ball up and all the way back up and see if you can put it back down there. Again, if you get in trouble, just put your foot down, right? So the patient, anytime they get going on that and these things, you stay close to them, but also get this idea, you can try this at home without the Dynadisc, just doing bending over. You can put the tennis ball all the way on the floor so it's a farther bend over, but it's really trying to get that good motor control from the ankle. The Dynadisc is also a great combination with the rebounder. Also use the Dynadisc against, say if you have your sound foot on and do a tennis ball bounce against the wall. Lots of different things you can do with this. Don't think we're showing you everything. It's just be creative in your thinking and what you can do with a patient to put them into a position where it's challenging to that left ankle, but not so challenging that they can't be successful. So if he just does some rebounds, And you can change the tension here by simply changing the weight of the ball on a rebounder. But this is making him take some of the right foot control away, making that left foot control more of the weight. Then, if he wants to progress that, what we want to do is turn and face towards the camera and probably bring this down his back just a touch right there. And again, so that foot's on. What he's going to do here is throw the ball, but when it comes back, go ahead and throw it, bring it back, and then I want him to rotate those hips and really see what's happening to that left ankle. A lot of load on that left ankle as he's rotating. Now, at the beginning, he may not be able to do that. He may just do a side toss without rotation and then add the rotation as he can tolerate more pressure. All the way back and push off. All the way back and push off, putting more and more tension on that ankle. Perfect. All right, Total Gym is also a great tool because why? You can adjust the height here, which determines how much pressure is on his ankle. So if we keep this height very low, he can go ahead and do a squat press up. He can do a press up, not too fast, just slow down, easy. There you go. Up and back down. Now remember, if he has restricted motion, as you come down, just stop right there, Hunter. Let's say as you come down and start coming down a little farther, you're going to feel that ankle start coming up because he doesn't have enough ankle motion to go all the way down. So what he can do is feel, when he feels that heel come up, and just oscillate right at that point. Go up and down just a little bit, right over that point, and work on improving the mobility of that ankle. At the same point, again, if I need to on here, straighten all the way up. With somebody like Hunter fairly quickly, I can put all your weight on this leg. I can come right in here and say, all right, Hunter, let's just take a few glides, moving that ankle to create better posterior glide of that ankle. Come back down in, and now come back down into that squat. And say, okay, there you go. I can go a little bit farther on that. So again, working on that motion. From there, you can add a little bit of impulse. Remember we said that's the thing we add next. So from there, you're going to do a little bit of a hop. So press up and a little bit of a hop and then come back down, all the way down. Always land soft kneed, so you're not putting too much pressure on the ankle, but you're starting to take a little bit of impact. If you want to make this more difficult, you just raise it up higher or have him jump harder. But at the beginning, we're just taking this slow to get a feeling of taking impulse on that leg without impact that's going to cause injury. So another aspect we want to do is just once you've got this feeling of control with both legs, is trying to go single leg one at a time. And what I like to do is have the patient start with the uninvolved leg first and move off. There you go, and come up. So he gets an idea of what does normal for him feel like. If he gets that sense of what normal feels like, then switch over and just say, okay, I'm going to be a little more scared here, but let me just see what happens. And if he gets in trouble, put the foot down. I always tell them, just point your toes, and if you get in trouble, put that foot down to help you out until you get a sense of the feel of control. So then you can get to a single leg squat or a single leg with a little bit of a hop motion. That's all that motion right there. I hope you benefited from the second video in our series where I demonstrated how to restore normative tissue capabilities to allow for return to basic skills and functions, as well as reestablishing comfort and confidence for daily activities. The key, I hope you see, if nothing else, is be hands-on and be creative. In video 3, I will introduce and demonstrate progressive higher speed agility training, power training, bracing, and activities/sports specific considerations. This video is part of a series on rehabilitation of the foot and ankle. We encourage you to view our other videos in this series and to share them as well. You can find them on our YouTube channel at youtube.com/MissionGait. To stay up to date on our latest content, click the link in the corner to subscribe and be sure to like and share this video. And if you enjoyed this content and found it helpful, please consider joining the mission and donating using the link below or using the donate button on our website, www.missiongait.org. We love providing this information for free to anyone using the YouTube platform. And it's all thanks to our generous donors and sponsors who truly see the value in this information. How about you?